Okay, I see we've got quite a few participants joining in here. I'd like to say hello to everyone and give a big welcome to our entire panel here today for today's webinar. Thank all of you for joining. So I'll start off. I'm Jennifer Curtin. I'm the Chief Medical Officer and co-founder at Rhythm. And I'd also like to, I'll be one of the moderators today alongside Charlie McCone from PLRC. And then we have our panelists, Zac Spiritos and Binita Kane. And I'm going to have us go around and each do our own introductions here so you learn a little bit more about us. So, Zac, do you want to kick it off?
Sure. Yeah, I'm really excited to be here. Thank you, Jennifer and Charlie. I'm a gastroenterologist by trade. I've kind of done some zagging over the past couple of years. I've loved IBS forever and the nuance and the complexity of it, and then discovered that mast cells were behind a lot of irritable bowel syndrome, and then I realized a lot of the patients had hypermobility and had motility issues, and I did a lot of GI motility, and then my practice has kind of slowly expanded to encompassing all the challenges that people with hypermobility face, but not only that, but also the ME/CFS element of this too. Um, that's me. Anita, what you got?
Yeah, so I'm Binita Kane. I am a respiratory physician by background, and I worked on the front line of the pandemic when COVID hit. Um, so I got interested in kind of the effects of COVID quite early on, and because I was one of the people who set up one of these big virtual wards where we were trying to get people out of hospital and monitor them and see like keep them safe because the hospitals were falling over. And I sort of realized at that point, really early on, that people weren't getting better. They were supposed to be on my virtual ward for like a week, maybe 10 days, 2 weeks, 3 weeks, 4 weeks, sometimes 6, 8 weeks later, they were like, we're still really sick. So long COVID kind of was something that was on the radar early. And then sadly had my own experience with my daughter falling ill with long COVID when she was quite young. She was 10 going on 11. So that sent me on a merry journey to try and understand everything I could about this condition and ME and looking back at the history of post-viral illnesses. And then fast forward 6 years, I've left my consultant NHS respiratory job. I've set up the long COVID clinic in the UK and now see people from all over the country who are at that moderate to severe end of long COVID and ME, and I do it full time.
Jen, do you want to give a little more of your background?
Sure. So I'm Jennifer Curtin. I'm an internal medicine physician. I had ME/CFS for about 9 years and also dysautonomia. And I'm hypermobile. I don't quite meet EDS criteria, but I have a lot of the things that I ended up learning to treat in my patients. As I went through the journey through medical school, through residency, I was getting worked up as I was in my training. So I was kind of going through on seeing both sides of the fence. And I've been treating patients with these conditions for quite a while. And then when the pandemic hit, I was very concerned that there was going to be a very large wave of people who were going to develop a lot of conditions in the wake of having COVID infections. And so I co-founded Rhythm to try and scale care for this inevitable wave of people that was going to become ill long term after COVID infections. And so that's how I am where I am right now.
Great. Yeah, and thank you all. Yeah, and I'm Charlie McCone. I'm a patient advocate for long COVID. I'm a first waiver, so I got sick in March 2020 after the CDC told me it would only take about 2 weeks to bounce back from my illness. It's now going on 6 years. I was 30. I've now spent my entire 30s, mostly housebound with this condition. In the first year of my illness, I was pretty much stuck in Kaiser, saw around 30 to 40 doctors. Out of necessity, started just, uh, joining the chorus of folks online trying to raise awareness that this, wasn't being talked about from our medical or public health professionals. And from that process, met a lot of the other incredible folks at the Patient-Led Research Collaborative, where I eventually joined as a member, now a co-lead. And through that process, also met an incredible doctor who was at One Medical. And so after my first year, I left Kaiser and started seeing a doctor at One Medical who eventually joined Rhythm. And so that's how I got connected with both Rhythm and PLRC. And I've been worked with them over the past year on this treatment guide, and just so grateful to both entities and for putting all the work into this guide. And yeah, excited to have this conversation today.
Awesome. Thank you, Charlie. And as we have more people joining, I just want to say, this conversation is around a guide. It is intended to be educational in nature. It's not intended as any kind of medical advice. So please, before you change anything, always consult with a licensed clinician before making any changes to your treatment regimen. Um, yeah, so I guess, Charlie, do you want to give just a brief overview of what the guide is, how it's kind of laid out, and like how it came together? What was the inspiration for it?
I'll share a little about the inspiration, and then maybe you can go into a little bit more about what it is, because I think you're better speak to that. But at the end of 2024, a colleague of mine, Julia Moore Vogel, and I wrote an op-ed in Stat News trying to basically make the case for clinicians to write more off-label medications for folks in our position, because we believe that do no harm in a lot of ways means giving us access to medications rather than us getting sicker and lingering with a very terrible quality of life. And so through that process, we got a lot of great feedback. And so I started thinking, okay, well, what would I give a doctor if we changed their mind, or if we convinced them to take a look at the evidence base? And I realized that there wasn't anything that existed that I felt like I would feel comfortable giving a physician who has a very, short, a few minutes extra in the day. There's a lot of great guys that are very in depth, but it feels like, something that is, more appropriate for somebody, on an undertaking to really understand the ins and outs of these illness rather than, taking a look at, a medication or two. The other two things that I've constantly was dealing with is about once a month, I still get messages from folks saying, hey, I developed long COVID. I have no idea what to do. And through that process, I've, gathered around 12 or so different links on check out this guy, check out this, check out that. And it's very overwhelming for a patient. So I said, wouldn't it be nice if there was just one thing people could go to that felt like it could work as some sort of checklist to work through as, potential treatments to try. And lastly, I feel like there is a narrative that if you get long COVID, there's nothing to do. And I feel like this narrative has been harmful in contributing to a lot of people not accepting that they have long COVID. And so I think there's a lot of people out there who see this as a dead-end diagnosis. And so they don't pursue any care or treatment within this context of long COVID because I don't think there's anything to do about it. And so while we still need an FDA approved medication, and as a patient advocate, that's one of the main things I spend my time advocating for. There's still a lot of evidence base out there for folks, with this condition to start pursuing things. And so I think as a community, I'd like to start, acknowledging that if you do have long COVID, there are things you can do. And, there's things you to try, and it's not a dead end diagnosis. And so all and behold, I brought this, to a few folks at PLRC and Rhythm, and everybody, thought this was a good idea. And I said, okay, so go do it. And so I'm so thankful for the brilliant minds at PLRC and Rhythm who really made this come to life. And so, yeah, that's kind of a little bit of the inspiration behind it. But Jen, why don't you share a little bit around kind of, what medications were included? What was kind of the criteria that PLRC and Rhythm was thinking about how to include medications in there? And then also, how is it kind of, laid out?
Sure. So the guide covers, just around like 30 or so treatments across several different spans. It focused primarily on prescription medications. That was the main focus of the guide. Um, but we did include a couple of other categories of interventions just to kind of show that there is some breadth of things that you can look at in terms of treatments. And so the first part of the guide is a table of contents. So you can pretty easily just look through and see, okay, what's in here? And you can easily navigate to whichever treatment you want to look at. The introduction is very critical as well. So we broke it down by categories. So the first section is prescription medications, and it includes several things in there. So there are various different kinds of beta blockers. There's things like Maraviroc, subcutaneous IG, IVIG, various different kinds of antivirals, including things from anywhere from Valtrex to Paxlovid, et cetera. And then there's additional medications like clopidogrel, or the trade name is Plavix, and several others. Then we also have over-the-counter medications and supplements. And so that includes things like things like antihistamines that are over the counter, nicotine patches, oxaloacetate. There's several other in there. We also have a category around procedures. That was kind of a little bit of that includes like stellate ganglion blocks, hyperbaric oxygen, and then there's lifestyle and kind of like activity modifications. So that includes things like pacing, compression garments, salt and fluid loading, etc. And so what we did was we tried to go over and summarize what are each of these things, like what kind of symptoms do these tend to help with? So you can kind of sort through and figure out, all right, based on the symptoms that I have, what things would I look at first, perhaps? Like what would I take to a clinician to have a discussion? And let's say you go to a primary care doctor and you've only got 15 minutes with that person. Maybe what you might do is you may say, okay, I'm going to bring in the introductory page as well as just the printouts for maybe these two medications. And I'll give them to that clinician. It's in a very short format, summarized what symptoms and conditions it tends to help, just what it is, the notes, a summary of the research. And then we did draw heavily from the Treat Me study, which was a very large patient-led survey. It was through Dr. Martha Ecke, Harvard, Stanford, OMF, all worked on this together. And it surveyed over, I think, 4,000 people with these conditions. And it said, okay, what have you tried and how did it help you, not help you, make you worse, make you better? And so we tried to look at was the intervention we picked included in that survey, and did over a certain percentage of people have like at least moderate to significant improvement on the intervention? And then we also looked at the evidence base. Are there studies to support this? What quality are they? How many are there? Did it show a pretty positive benefit for people in at least some or the majority of studies that have been done on it? So that's kind of how we picked the guide contents. That's how we laid them out. The design was intended to be for starting a conversation with a clinician in a limited amount of time where they don't really have time to read through a lot of info. It's kind of a 1 page per treatment format to just facilitate that for the sake of time. And we do also mention several other incredible guides that have been done for folks who have the time and want to do that deeper dive and really learn in more depth about these things. But a lot of times clinicians don't have the time to do that. So this is kind of the short, succinct version that folks can use.
Great. Yeah, that lines up with my recollection of what happened. And yeah, thank you for laying that out so quickly. So would you say that is kind of what makes this guide unique? Is that the kind of basically the format of it and kind of it being, something you can take to a primary care doctor that, who has 10 to 15 minutes to look at something? Or is there, anything else that you think that makes this guide unique according, with the other great guides that are out there?
Yeah, I think that's the primary thing. It's just the form factor.
Yeah.
It's just the ability to, just take a page or two in an intro and bring it in for a real short visit.
Okay, great.
All right. And so I guess, Benita, I'm going to go over to you. What's your impression of the guide, and have you found is this something helpful for you, for your patients? And are there any treatments in the guide that you regularly use with any success in this patient population?
Yes, and yes, really. I think the guide's super helpful because we don't have a national guideline in this country. We have a nice guideline for ME and long COVID, but they don't generally include treatment options. And then we've got some consensus guidelines from the States, from Mayo, and then useful guidance that's been put out by Mount Sinai, etc. But there's nothing concise where the key core treatments are kind of in one place with the information synthesized in a way that patients and doctors who are non-experts can understand. And it's very practical. So that's what I really like about it. So actually, I'm using it all the time. So I use a lot of the drugs in the guide, all the POTS drugs that are in the guide, all the MCAS drugs, LDN. I use a lot of them. And I do use low dose rapamycin as well in selected patients. And so having that information at my fingertips, I can almost like copy and paste it into my clinic letter to say, here's some information for you to think about. And so for me, it's been really, really helpful like that. And also, I think for patients, it gives them a visual of, okay, well, these are the things that are practical that I can go and speak to a doctor about. So yeah, thank you for putting it together, guys, because it's great.
Wonderful. Zach, to you, I guess just the same question. What has been your impression of the guide? And is this something, that's been helpful to you and your patients? And then are there any treatments that you're regularly, using with any success?
Yeah, no, I like the guide a lot for sure. It is sometimes, you know, in this space, there's a lot going on and a lot of symptoms happening at the same time, and sometimes you don't know which way to look. And there's a lot of different directions that one can go, and sometimes having a piece of literature that you can go back to that works as a really nice anchor to say, okay, like kind of what have we done, what has worked, what hasn't worked, and then yeah, it provides some guardrails for the future. For patients alike, I've had people come to me and say, hey, can we try this, can we try that, I've read about this. And I think that up until this guide, and there have been certainly other guides in the past, but patients have used other patient experiences to kind of substantiate what they like, where to go next with their treatment. So this kind of
Right.
gives a backbone and research driven suggestions. And that's what's cool, is that you also provided kind of granted, there's no very little randomized control trials in this space, but there are observational trials, and there's mechanistic data like the tirzepatide piece, right? Like that's more mechanism than anything else, and maybe a case series. But I think it gives patients, I don't know, like some vision for the future, that there's some options out there. Because as Charlie mentioned, like it can feel quite hopeless at times. I use a lot of these there. I mean, this is the world I live in, so I use all these therapies. Certainly, it's there are, I kind of try my best to phenotype people to the best of my abilities and say, like, what are your symptoms, and what have I seen work for these collection of symptoms? When someone has fatigue, let's dive into the kind of fatigue that you have. When someone has PAM, let's really dissect it. Is it like you crash right after work? You exercise the next day, and I find that certain medications work better for others, and trying to pair like why something works with the mechanism. But man, these are all tools in the tool shed, certainly.
Okay, great. Um, that's wonderful to hear.
Yeah.
Uh, uh, One of the main feedbacks that we've gotten from patients that the guide has been out is, this is great, thank you, but how do I bring this to my doctor? And is this something they're going to be receptive to? And am I going to get knocked for doing this? So I guess like a question to all three of you, and I'd love to hear all of your different perspective, is, do you have any recommendations for patients out there on how to bring this guide to their doctor? And do you think PCPs, will be open to reviewing, this type of guide? So yeah, any tips, ideas, or just acknowledging that, this is still hard, that works too. Why don't we start with Benita?
Yeah, so I think this is a really difficult area because in UK we have a National Health Service which is publicly funded, and therefore everything that the NHS does has to be done in a certain way, approved by certain mechanisms. The funding has to be improved, and that also includes drugs. And then we have bodies like NICE that kind of oversee what drugs you can and can't have. So even if you took this to your doctor who had the best will in the world and really wanted to help you and wanted to prescribe one of these things off label, they have rules that they are not allowed to do that. And they could actually
Wow.
get in trouble if they prescribe some of these medications off label against the rules. And that does happen to people, so you're trying to do your best, but you can get yourself into trouble. So I think that that's why many people in the UK are kind of forced into the private sector to get these drugs prescribed. And you can go, unfortunately we don't have health insurance in the same way as you do in the States, and therefore that narrows the number of people who can access. So you could come to a clinic like mine, but clinicians like me are completely overwhelmed with the demand, 10, 11, 12-month wait to for the clinics, some of them. So I think it's really hard. So I don't want to kind of be negative about it, but I don't think this guide in itself in the UK going to a primary care like a GP, a general practitioner, is something that they will equate to them getting prescriptions.
is there any guidance for any medications for folks with long COVID in the UK?
In a sort of a roundabout way. So if you can find yourself somebody who is experienced at diagnosing POTS, for example, by going to
Right, I
a
see.
cardiologist with an interest, they would be able to prescribe certain medications for POTS. Or you could go to, if there was an allergist who had an interest in MCAS, and that's difficult to find actually, then you may be able to get some of these
Right, I
prescribed. It
see.
tends to be kind of, you'd have to go to various different specialist clinics to, and even then, there may be rules around what can and can't be prescribed off label. So in the public sector, that's what makes it really difficult. And that's why people like me have to go and practice outside of the NHS, because you
Right.
wouldn't be allowed to do it in the NHS.
Got it. I see. Gosh,
Tough.
that's
Yeah.
difficult. Well, Zach, how about what are your thoughts on this, I guess, from from a US perspective?
Yeah, fortunately, we're able to prescribe. There's not as many limits. Sorry, I got a lot of feedback that I'm speaking way too fast, and I get this all the time. So I apologize for everybody, and I will speak slower. So there's not as many sticking points in the US in terms of being able to prescribe medications, even off label. Occasionally insurance will have issue with it, but there's a lot of means to get off label medications for pretty cheap, especially the medications here, maybe save IVIG and tirzepatide in certain situations. It's a question that I get all the time is how do I talk to my provider about this? And I will say that in the current system where there's 15 to 30 minutes to dissect someone's history, and more often than not, someone who's dealing with ME/CFS, MCAS, dysautonomia has about 60 to 70 things going on. And the PCP gets immediately overwhelmed by it. So I agree that it would be challenging to present this to I think, an average primary care doctor. I think it's hard for them to digest all of this because a lot of these medications they probably don't use with regularity. That said, there are PCPs out there that are willing to dive deeper and be creative. I've found you have to search for them though, and so I think you have to find the right champion of your care who will be in your corner, willing to listen to you and dissect this guide for you. If I was going to give one piece of feedback for the guide, it's to say that what do these medications do, right? Like what does rapamycin do? Like what symptom cluster does that work for? And it's in the paragraph certainly, but if that was arranged in the table of contents, to be like, okay, patient, post-exertional malaise. Okay, well, here are my options here. I think that would streamline the process. I think you just need to make it just as little friction as possible in someone who's really, really busy. But I think the average primary care doctor, I agree, it's hard to start this dialogue because it can be easily overwhelmed with the symptom burden, but also all these choices that they are rather unfamiliar with. But I think it starts with identifying someone who's willing to listen, be curious, and be creative with your care.
Yeah. Yeah. And I just want to acknowledge, as somebody who has found a physician who is willing, to try this, that this guy doesn't solve for that. And, this is still a big problem that we have, with care, around the world is finding folks who are willing to getting access to these drugs. Uh, I guess our question is, we have gotten feedback from folks at PLRC that some of their PCPs have been receptive, which is, really great to hear, and they have like the guide. Would it be, do you think PCPs might be more receptive if they're seeing, an intro to the guide with, here's one or two medications I'm interested in, as opposed to, hey, what should I do with this guide? Do you think like that might be, PCP might be more receptive to that, approach, if you can kind of go in with, like, hey, this is the drug I want to try, and here's the evidence, and here's, the summary, and here's what it supposedly does, or whatever. Do you think, that might, grease the wheels a little bit more, or can that backfire as well?
I think do you mind if I jump on this? Is that
Please,
okay?
please, yes.
Yeah. So I think that that's the exact way to do it.
Okay.
You want as little friction as possible. And you
Yeah.
say, okay, like this is what I'm dealing with. This is the symptom that I have. If some of these medications have case control studies behind it, it's even better. It's like, hey, look, this is here. Like people do okay, and here are the side effects.
Yeah.
The good news is that generally speaking, most of these medications are really well tolerated if prescribed appropriately for these conditions,
Right.
right? Because I think the other hitch here is, how does one dose rapamycin, right? Like, how do you acquire it, right? And there are answers to those questions. But if I'm a PCP, I was like, goodness, like, how do I even start this process? There's nuance to prescribing cromolyn and mestinon in patients as well, amongst all these things. So it's, I think there, if I were to say, what's the best way to really put this like kind of white glove service these medications to providers, it's
Yeah.
like, this is what I'm suffering from. This is how this medication works. This is some data that it works. This is the side effects. This is how we dose it, because the dose thing is really important as well, right? You can't go 0 to 60, right? And this is how to acquire it, because some of these medications can be difficult. Ivabradine, for example, like not all insurance companies cover that, but Mark Cuban's pharmacy in Florida, you can get it for $10, right? Sirolimus alike. And so and so I think there's the clinical applicability. What do we need to look out for? And then shoot, how do we pull this off?
Super, super helpful. Jen, anything else you would like to add to that?
Yeah, no, I think it really is like Zach did a great breakdown of that. I think it's trying to be as targeted as possible and really just kind of go, walk them through. I almost think of it as like I'm presenting like a legal case almost in my head, when I'm trying to convince, like, let's say one of my clinicians or something, back when I was going through all of this, it was like, okay, how do I get into their mindset and say, all right, they've got limited time. They want to know that whatever they're going to give me is going to be safe for me, has a decent chance of being effective, and isn't going to like get them in trouble. And they want to know if they are going to be dosing it correctly. Because let's say it's something like low-dose naltrexone. Most of the time that's compounded. And a lot of clinicians have never prescribed a compounded medication before in their entire career. Because when we go through medical training, at least, and this is speaking to the US, and I imagine, Benita, you can say whether or not UK as well, but we're not taught to do any kind of compounded medication. It's completely foreign to us. That's something we only learn outside on our own when we've kind of had to learn it. And so, someone may go, oh, well, the standard dose for naltrexone is 50 milligram tablets. And you're like, wait, that's way too high. That's not the dose we're using. So they're like, how do I get like zero point 0.5 or 1 milligram or 1.5 milligrams when the smallest tablet size I can order is like 50? And they're going, how do I do this? And so they have to, figure this out, and they're learning all of it from scratch. So having something that can walk them through the logistics of how to get these is helpful. And, this is something, maybe in the future of the guide, we can kind of start to add some of this stuff in. But also things like, for instance, yeah, let's say your insurance doesn't cover Ivabradine, which is super common. And, CVS is trying to charge you $600 for it. But yes, at Mark Cuban's pharmacy, it's notably cheaper cash pay, like significantly cheaper. And so it's just knowing little tips and tricks about how do I even get this? Is this safe? Is there a decent chance it'll be effective? Am I going to get in trouble? And then what are the logistics about actually accessing this for the person? And that includes, how do I get this for the person in a way that's cost effective? And so I think having that kind of set of things ready to go when you walk into a visit is helpful. I know that we've got a free AI platform that people will ask the AI platform to like write up a summary for them. And, some people will do this with like GPT or Claude. I would say if you use that, make sure you turn off the data sharing. If you're putting any of your private information into an AI, like turn off the data sharing setting. And you can ask it to write something up for you, like write up a conversation guide ahead of your visit, to go over certain things like this. And just basically have it ready to go. Some people will not be open-minded to this no matter what. And some systems, it sounds like the UK, and I saw some comments that Canada might be similar. I'm not super familiar with the Canadian system, but in some cases, the clinicians are very boxed in on what they can and cannot do. And it may not be for lack of wanting to try, but sometimes the system is just very restrictive. Thankfully, at least in the US, it's not that way. But yeah, and sometimes you have to keep hunting for clinicians who will be open-minded and willing to listen.
Yeah. And again, I just want to acknowledge that, this is still very difficult for a lot of patients. And our goal with this guide was to try to eliminate some of that friction. And, one part of that too is one piece of feedback we also heard from a physician is that this helps if I know I'm not the first person in the world to ever do this. And so having one other, strategy we tried to employ not just for that, was to also list that the other associations and organizations that are prescribing this for this indication. And so that's also, listed on each, medication page as well. And so we hope, this can help, you know, eliminate some of the friction in folks trying to get access to these medications.
Yeah, and it
I
may
think
not
the
be
other
able
thing,
to.
oh,
Oh, sorry,
sorry.
go ahead, Benita.
No, I was just going to say the other thing that is worth thinking about is these drugs do have licensed indications. So if you fall within that licensed indication, you could go and talk to your GP about that. So ketotifen, for example, is like licensed for rhinitis. So if you have rhinitis, which a lot of patients with long COVID have, you could go and say, well, can I try it for this? Or, can I try antihistamines for my allergies, as opposed to saying I've got, because sometimes when you say the words long COVID, the shudders just come down over the clinician. I don't know what the reason. Well, I kind of do know the reason. I think people are very traumatized by the whole pandemic. People don't want to think about the after effects and the long COVID, and it as doctors who aren't trained in how to manage it, they can find it very difficult being faced with a patient who has all of these difficult, complex, overlapping problems. So you can break it down into licensed indications that can be helpful. You take a 15-year-old to a GP and say they're anxious, they'll put them on sertraline. But if you say I want to try sertraline for POTS, COVID-related POTS, that absolutely no. So it's that kind of thing. It's obviously be truthful, but if you have got that licensed indication, that can be helpful.
Great.
Okay. And yeah, I guess so. Moving on into some of the next set of questions. So, Charlie, I did want to ask you, you've tried a lot of treatments throughout your time
Mhm.
being a patient suffering with this condition. Um, and there and many more in this guide. How do you find the endurance to keep trying medications, especially when, let's say, you go through several and they may not work, which is very common, right? A lot of these medications, they'll only work for a small fraction of patients, and they may only work partially. How do you keep up that endurance of continuing to try things?
It's easy. No, this is incredibly difficult, and it's an awful, situation that, for care that patients have to go through. And I just want to acknowledge that for anybody who's not there, that they're kind of like, I don't want to be doing this right now. I don't, the strategy does not work for me. I think that's completely valid. And I don't want to insinuate that this is the only way to pursue care or this is the right way or anything like that, because I think this is very hard to do. Um, I was in a headspace personally on my own journey a few years ago where I was exactly there, where I was like, this is not fair. I should not have to keep trying different medications to figure out if they're going to work or not. There's like 50 medications to try. Each one takes like 3 months to figure out if it's going to work or not. So I get through like 4 medications a year. This is going to take like 10 years, to get through all these medications. And I was feeling very demoralized about the situation. And at that time, I was, kind of tweeting a lot about this. Another great ME advocate reached out to me, and she kind of leveled with me, and to kind of paraphrase in my recollection, she was like, dude, I think, your best chance of, getting better is to continue keep trying things. And she's like, that's the way I see most people in this space get better. She did acknowledge, some people do get better, on their own with convalescence, but like it's not particularly common. And so, if you really, you got to start trying things. And I kind of had this moment of just like, gosh, she's so right. and I need to kind of re-engage with this process. And through, and I have found two medications that have worked with me. Plavix was the only thing that touched my shortness of breath, and that was a godsend. I tried every inhaler, and it did nothing. And then LDN has helped me quite a bit with my global symptoms. And so my life, I went from, not wanting to live to having two medications giving me, the will to fight and to keep going. And that's huge. Um, the other thing I realized is I got diagnosed with migraine, a few years ago, and I went, there's 30 FDA approved drugs for migraine, at least. And I went to my neurologist and I was like, okay, so what's the plan here? And the standard of care started looking very similar to what I was going through with long COVID. It's like, okay, there's these drugs. We're going to try these drugs. If they work, great. If not, you're going to go to the next one. I say, wait a second here. There's 30 FDA approved drugs and we still don't know which one's going to work for me. And the answer was no. And so I kind of came to this realization that with conditions like asthma, like migraine, and a plethora of other chronic conditions, the process for trying to find something that works, the standard of care, is exactly the same as it is with long COVID, with just, a little bit with a bit more evidence. And so I kind of came to the place where, I might as well get a head start on figuring out which drugs are going to work for me or not. Just because a drug is FDA approved does not mean it's going to work for me. And so I'm not going to wait for these drugs that have compelling case studies, that have a good safety profile, to figure out if they're going to work for me or not. That was kind of my journey. That's been my decision. And my hope is that for folks who are also in a similar place, that this guide can help with that process and not having to, string a bunch of different Reddit posts, together to figure out what to try next. And so, yeah, I mean, I think that's just where I've landed on that. Again, I understand people who are not in that place, and I don't want to insinuate that this is the only way, but that's just where I have found my um, you know, journey to keep going. And I haven't tried every drug in this guide. And I will say that in the process of making this guide, and somebody who's in the weeds every single day, with this stuff, I found a couple of medications where I was like, why haven't I tried this yet? They're like, wait, this is a pretty compelling case study at a very well respected institution, and it helps with the symptoms I have. Uh, and so, um, I'm still on my own. I'm still with my journey of trying to get through all these drugs. And so, yeah, that's kind of, it's hard, but, that's where I've landed. Um, I guess that leads me to, a question of, I guess, to the clinicians here, what percent of long COVID patients do you think would find at least one thing that works for them if they were to make it through all of these guides, to make it all the way through this guide? And Jen, why don't we start with you?
I would say somewhere between, I'd say 75 to 80% would find some benefit from at least one of the treatments. Now, I wouldn't say that this is like oh, it's going to cure you. It's like, no, you may find some degree of improvement from at least one thing on this. The guide covers a pretty wide spectrum of phenotypes of folks who have different kind of like classes or categories, different underlying conditions that are driving the long COVID that they have. So that's kind of my just like gut instinct from just having treated patients and seeing these drugs used.
Uh, Zach or Benita, any other thoughts on that?
Yeah, I can come in. I find it hard to put a percentage on it. And of course, I see quite a skewed population because I'm seeing the moderate
Yeah.
to severe end. But even at the moderate to severe end of the spectrum, I think with the right help and support, everyone can improve genuinely. And that will not be just drugs. It's really important to say that the drugs are a part of a wider management plan. And I will never apologize for mentioning pacing, and more pacing, and making sure that alongside drug treatment, that those lifestyle modifications for POTS, the fluid, the salt, the compression, the pacing, sorting out sleep, sorting out nutrition, all of those things are super important to do alongside medications. Medications will only work if you're also driving the car in the right way, like you're not revving the engine too much and overexerting. So I just wanted to like make sure that we're not losing sight of that these drugs are not like a miracle cure. But a
Right.
lot of the time, I think people do need those medications for symptom support to even get them out of a hole, to get to a point where they can engage in all of those other things to be able to improve. And some people can't even engage in pacing well because they're just stuck, or they're too brain fogged or what have you. So I think that symptom support, getting things stable, is super, super important. And a lot of these medications can help with that, particularly around MCAS and POTS.
Yeah, it's it's such a heterogeneous group, and that's what's so frustrating. That you think the same the same pathology should be present for all these people. If someone has heart failure, generally speaking, the same mechanisms are happening in most people with heart failure. In this, there's such variety, whether that's people are more mast cell driven, more dysautonomia, and then baked in that is this more endothelial dysfunction, is this hyperpots, someone's blood pressure live 80s over 40s. And so I agree, it's hard to put a number on this, but this definitely touches on a lot of the potential variables that could be at play. But to Benita's point, they're complementary, and medications probably take up 15% or 20% of the conversations I have when I first meet somebody, because there's a lot of other it's a complementary piece, and the basement floor therapies are usually the lifestyle pieces, and that's a whole kind of different conversation of itself. And you guys touched on a lot of great ones here, but the EMDR part of things, the sleep, the graded exercise, there's a lot of different inputs here that all need to be at least addressed during a visit to provide comprehensive care for a very complex issue.
Yeah.
Right.
No, definitely, you have to look at the whole person. And the guide is not comprehensive by any means. There are a lot of other treatments out there. There are a lot of things that can be done outside of that. They're very like kind of the holistic and supportive. We focus primarily on the medications in the guide just because we figured that would be highest yield for just like an initial conversation. And we had sort of the basics of like the lifestyle management. So that's your fluid loading, compression, pacing. But there are a lot of other things out there. There's a lot where there are emerging therapies. There are things that people are trying and having success with anecdotally. There's trials going on and other things that we're waiting for the results for. So I think, don't take this guide as like oh, this is all there is. It's like, no, there's definitely a lot more around that. And for instance, yes, like Zach, you mentioned sleep. That is so critical. We didn't really get into sleep medications. Another thing in the guide, what we didn't do is we didn't really go into conditions that have standard guidelines for them. So for instance, like migraines that, Charlie mentioned, a lot of people have headaches, have migraines as part of their long COVID presentation. But because there's an existing framework for managing migraines, we didn't really go into migraines in the guide. Same thing with like someone who may have developed diabetes as a result of their COVID infection. We didn't really go into that either. So, but all of these are important. Sleep, mental health components, it's really hard not to become depressed or anxious when like your life has been stripped away from you and no one's listening to you. And also things like, yeah, what do you do around activity? Making sure, and then I've seen some really great comments in here about there's a workup that needs to be done in parallel with this. Not everyone's going to be able to access that workup, but do you have things like, do you have viral reactivations going on? Do you have any, like, how is your immune system doing? I'm not sure, Benita and Zach, but if you guys are seeing this too, but we're seeing a lot of immune dysfunction in these patients. Like their immune systems, either immune deficiency, and we're going, wow. And, we don't know if they had this before and it just maybe got worse, because a lot of people, when they were, feeling relatively well, aren't going to have this workup done. So we can't, for sure say that COVID caused it, but we're seeing a lot of it. And, I wish in particular IVIG and subcutaneous IG were much easier to get for people, because we are seeing decent responses to that treatment in particular. But, I'd be interested to see what you guys are saying in terms of immune system in particular.
There's definitely broader immune dysregulation here. I mean,
Yeah.
everything from MCAS, which is what that is,
Mhm.
but there's also some people have a lot of prior infections and get sick with everything that their kids bring home. And then there's that two sides of the coin, the autoimmunity and immunodeficiency, right? They're kind of one and the same, or not one and the same, but it's broader immune dysregulation. Rarely do people fit like in one camp. It's just it's broad immune dysregulation. So one part of this as well is the the autoimmune piece of things. A lot of people have comorbid autoimmunity, a lot of joint pains, a lot of fatigue, that that swelling first thing in the morning, that feel very lupusy, but don't quite meet criteria for that. And that's another kind of flavor of this too. Yeah, so that's the immune dysregulation part. What's the workup look like for the PCP who wants to work up somebody who has a lot of infections? Like, what does that appear like? That would be kind of a cool flavor to this too, or feature. Other thing is like the GI dysfunction here, and that's obviously like, I'm going to put a plug for everybody pooping properly. And most people have some GI dysfunction. And how do you think about that? And how do you break that down? What medications work better? Like, what laxatives work better than others? And so there's nuance here. Like, when you hear nausea, like, what is that? What treatments? Because it's the medications to kind of help with the ME/CFS and the MCAS and dysautonomia. But what happens if someone has really, really bad nausea? Like, what do you use for that? Like, the tools are, I think, a little bit different for folks dealing with this compared to someone who just, ate bad Chipotle.
Yeah, I'd agree that I'm seeing a lot of low-level immune dysregulation, in the sense that slightly reduced lymphocytes, slightly reduced neutrophils, maybe a greater susceptibility to viruses and infections than people had before. People who never had UTIs now suddenly having UTIs, and growing weird bugs like Klebsiella. So but it's not to the degree that an immunologist is interested, because they'll go to immunology, they'll check levels rather than function, and they'll say, well, it's not low enough for me to do anything, and this person doesn't qualify for IVIG or what have you. So I think there's a lot we still don't understand about what that dysregulation is and how that translates into symptoms, and then what we do about it. So, that can be quite challenging.
Yeah, no, definitely. And I guess, Charlie, I'd love to ask, because I've seen a couple questions pop in here where people are asking about kind of like almost feeling over like, where do I start? And, just considering the breadth of treatment options, even listed in the guide, and the guide doesn't list everything. Do you have any tips for someone who's newly diagnosed about how or where to jump into a guide like this?
Yeah, I'll give the patient perspective, and I'd love to hear the clinicians' take on this as well. But for me, it's pretty rudimentary, and it's what is your kind of, are you falling into kind of a clear phenotype? Are you falling into a clear phenotype of of ME, of POTS or MCAS? If so, then that kind of can point you in the right direction. All right, let's check out the POTS drugs. There's there's a handful of drugs that can work for PEM, and then of course there's the mast cell activation drugs. I think once I would consider that as a patient, kind of your first line, approach for treatments. And once you kind of get through those, or if you find a few things that work, then it's like, welcome to the abyss. And let's I don't really have a good rhyme or reason of what to try next, but I guess like to turn it back on you all, like, have you found any sort of kind of clinical method or intuition of figuring out what you think will work, for a patient? Or are we just still waiting on technology and research to give us like the phenotypes of biomarkers that we need? But I guess beyond the kind of like, three classic phenotypes, like, is there any other kind of clinical, tools or that you use to help kind of like, well, let's try this. Why don't we start with Benita and then Zach, then Jen?
Well, I think firstly, I'm seeing a lot of patients remotely because they can't travel, and we see people from all over the country. And therefore, you have to really be quite innovative in how you do things. So data gathering is hugely, hugely important. So they have an hour with my specialist nurse before they will see me, then I will see them for an hour. And I want to know everything. I want to know right the way from birth, what was this person's birth like? What was their childhood like? How have they got to this point in their life? What are the factors that have contributed to them getting sick? And I see pattern after pattern after pattern, you know, people who had IBS and some mild asthma and maybe have got some neurodiversity in the background or had some anxiety as a child. They had shingles when they were 8, really strange sort of things like that. And you can see the pattern of immune dysfunction right the way from early age. Then you do a very comprehensive assessment and you collect data on from their wearables. You can do 24-hour ECG, you look at their blood work, basic blood work. And my approach is treat the treatable. Okay, so if they have POTS, treat that. If they have MCAS, treat that. If they have B12 deficiency, we treat that. If they're low in iron, we treat that.
Right.
So we treat everything we can. If sleep's disturbed, have you got sleep apnea? Let's treat that. And then alongside there is absolutely relentless pacing. Okay, and we are really like, you know, we'll make people pace really hard, but within a science-based way. This is based on the science of lactate thresholds, anaerobic thresholds, not exceeding your ability to, you know, what you can do. And then there's this kind of third pillar, which is really about sometimes people don't have a defined illness, but it doesn't mean the thing is normal. And by that, I mean, you've not got lung disease, but that doesn't mean your breathing is normal. So if you've got dysfunctional breathing, we will work on that. And then looking at that kind of what makes people healthy. You know, is their gut okay? Do they have gut dysbiosis? Is their sleep okay? So it's those 3 pillars really that I will work with people for on average for 18 months to 2 years, because it takes a long time to really kind of supervise those drug trials and tweak things and support them in the right way. And then they'll see various members of my MDT team who can support with them with those sort of holistic aspects. And it's building blocks. I say we need to get this building block in place and that building block in place, and eventually you'll have enough building blocks that we can tip you into that recovery. And that whole process can take 6 to 8 months. So it's painstaking and it's really hard work. And this is why waiting lists are so long. And it's hard work for the patients because they're having to do all of that themselves. So there is no easy fix to this. And the drugs are an important part of that pathway, but as I said earlier, they are only one part.
Cool. Zach?
Yeah, so I use a very elegant tool, and that's just listening. I think that I started out in like the IBS world, and there's just no good data, and there's no good biomarkers to assess what's driving somebody's IBS. And so it's trying to phenotype people as best as possible. Like, so when I start with IBS, like, what does your pain feel like? What are your triggers? Is it high? Is it low? What does it feel like? What makes it better? What makes it worse? And then identifying what buttons to press as opposed to just rotating medications. And I do the same thing, I think, for this. I think I've tried to identify and kind of put people in different buckets for MCAS, and there's overlapping buckets, but I think there's a few phenotypes of MCAS that respond to certain medications. So I start with like a really big symptom list, right? And so people fill out big questionnaires, and off of that, it's like, okay, so, and then I talk to you like, what's really bothering you the most? Like, what is impeding you from to being the person that you want to be and doing the things that you want to do? And let's deconstruct that symptom. So I've always tried to take a symptom and then ask, like, what's the mechanism? What is, like, you know, when someone has endothelial dysfunction, like, what kind of fatigue does that cause? Like, when they crash, well, what kind of crashing responds to mitochondrial support? What kind of crashing responds to MCAS support? Because I think if you dissect symptoms, you can get clues from like what is driving it. And that's kind of and then, you know, and talking about triggers as well, right? So when some people says, you know, goodness, like when my boss calls, I really flare and I go into a crash. I was like, well, there's probably a lot of sympathetic overdrive here. Let's talk about that, right? And you kind of like, you not only identify the symptom, the qualities of the symptom, but also the drivers for it. So sometimes patients will come to me and like, I want to start this, man. I was like, well, what goal? What are we trying to solve here? Is it fatigue? Well, let's break down your fatigue, because there's a lot of different flavors of fatigue. So I think all these symptoms are not created equal. There are a lot of different inputs here. So it really starts by listening and deconstructing a symptom to get a sense of what do we think is driving it from a pathophysiologic mechanistic perspective. And then what are the ancillary things that we need to pay attention to, whether it's diet, stress, sleep, the intangibles that really play a big role into why people feel the way they feel as well.
Getting back to the old school, isn't it, Zach? Like, just
What
listening,
about,
taking a history, examining if you're lucky enough to see someone in person, and then really going, what do we know from the science? And how do we apply that to what we think's going on in this person? It's really getting back to kind of that old school for being a physician, which I feel like we've lost a lot with all of our modern tools, but we don't have any modern tools for this world, do we? So we have to really go back to that doctoring that that physicians were, the old school physicians used to do.
Yeah, because you think that when someone comes in with, a stack of records this big and 74 symptoms, I'm going to order $3,000 worth of blood work. I order nothing usually from the first visit. Zero. Well, to be fair, most people have had the smorgasbord of workup before they come in, but rarely am I ordering new things because I just find them reliably unreliable. Things that I thought was going to lead me down a pathway have deceived me. And then I have the conversation with the patient, like, why did you order this? Like, this didn't, if this is positive, shouldn't I get better with the treatment for this? I was like, you're right. I don't have a good answer. We just order tests because that's what we do. And so I've kind of gone away from, certainly if I will order tests in the right situation, but I've become, uh, yeah, I think you can get a lot more from the story than a stool test or urine test.
Yeah.
what a fresher breath there to hear. So nice. Jen, would you add anything to that? Like, is there anything you use, anything you do as a physician to start thinking beyond, okay, what's going to work for this person?
Yeah, I mean, honestly, it's the same thing that
Yeah.
Benita and Zach have said. It's really listening, understanding that chronology, and like really going back, like as Benita said, going back to like birth, even understanding, the parents, because, as we're learning more about epigenetics, right? Some of the things about your parents or your grandparents can impact you in a way. And so it's kind of the really trying to put that together, pick those patterns out. What was underlying, perhaps, that maybe someone didn't realize? Even like professional athletes, right, will have some subtle signs and symptoms of hypermobility, of a little bit of MCAS. And you're going, okay, this may have been the underlying current there. And then this, infection or series of stressors and infections was the thing that just like that was the straw that broke the camel's back. And you're like, okay, that gives me at least a place to kind of start. And then it's really listening and dissecting out, as Zach said, like, what are the little clues here? What should I be testing for? Now, like, I do tend to run a pretty standard panel on most of the people I see. I will take things out if they've already had them done. But to try and give me a sense of, okay, what's your clinical phenotype from like the history and the exam I'm able to do, usually remotely? And then what am I seeing on your laboratory testing? And I try to have to like fuse those together and say, okay, where do I think the majority of your pathology is? Like, what may be driving the symptoms that you're having? And how can I piece together a story that makes sense? And then what additional testing do I need to fill in that story and confirm whether or not that is what's going on? And then that kind of helps push me in directions of treatments to try based on, let's say you have a bunch of coagulation markers that are off and you're having a lot of shortness of breath. That may push me more in the direction of your shortness of breath may be endothelial dysfunction, microclotting, rule out a pulmonary embolism. And like, let's go more of the coagulation shortness of breath pathway as opposed to like the asthma and like reactive airway related shortness of breath pattern. So I may like choose different treatments based on that. But this is the challenging thing about this area of medicine is that it is so personalized and so individualized that it's very hard to standardize it. It's hard to train additional clinicians because there isn't just like a clear, clean algorithm that you can just be like, if A, do B, if B, do C. You have to learn this all by just getting in there, reading a bunch, and then just treating and seeing it over and over again. And that's what makes it very hard to train new clinicians, bring them on, because it's a very time-consuming process. It's very in-depth and it requires just a lot of experience.
Yeah, the reps are really important. Just getting in there. But what's lost in that dialogue, and not intentionally, like you obviously are very, very aware of this, is the trial and error part and the part of the patients, which Charlie alluded to very, very well. It's like, we can try this. I think it's going to work. We're going to watch you very carefully, but trial and error is really, really hard
Yes.
because a lot of the things, albeit seemingly innocuous on paper, to someone who's dealing with MCAS and dysautonomic ME/CFS may throw them into a flare for 3, 4 weeks. And so that is a really hard discussion every time that you put someone on the medication, because it's like, I do this with the best intentions. I really think this is going to work. There's a chance it may not, and a chance it may make things worse, which is really a really hard part of this for patients and providers, like more so certainly for patients. But it's hard. It's hard.
Okay, well, if we don't mind, I'll wrap up with kind of one last question, and then if the clinicians have time, we'll stay and try to answer, a few of the questions afterwards as well. But so I guess just to wrap up, are there any treatments any of you are interested in that are kind of emerging that are interesting that you think, deserve maybe a little bit more attention or conversation, or that you're just kind of watching from afar that could be, meaningful for patients that are kind of not part of the kind of general discussion, at the moment. Why don't we start with you, Benita? And it's okay if the answer is no, or you'd rather pass the baton.
Yeah, no, I think, I mean, the guide covers the kind of the main ones. I think, I know, Jen, you said it doesn't cover treatments that already have clear guidelines, but I just feel the need to mention hormone replacement and HRT, because, hormones are absolutely, long COVID and ME and hormones is a massive interaction, and MCAS and POTS, it's really related. So actually getting people on good decent hormone replacement, especially if a woman is of perimenopausal or menopausal age, but even in my teenagers, putting them on the pill can sometimes be absolutely game changing. So that's just something we shouldn't forget. And I think the other area which is really of interest is the endothelial dysfunction, the abnormal clotting, the greater risk of cardiovascular disease, etc., that we're seeing post-COVID. And I'd really like to see more research going into, I think that the evidence is there from the science, but what we're not seeing is that translating into trials of treatments of things like clopidogrel and anticoagulants, and so that we know which patients should have those kind of treatments, what are the biomarkers, how do we do it safely. So that's an area I'd really like to see getting more attention as we go forwards.
Great. Zach, why don't you go ahead?
I pay a lot of attention to immune dysregulation, so I find a lot of benefit with medications that really change the dynamics of the immune system, whether that's Plaquenil, for the right person, not for everybody. So I think that's the one thing that I'd add to this is the autoimmune piece of things, because there is quite a bit of autoimmunity. I mean, IVIG probably works by balancing the immune system, right? And then obviously through a lot of crazy cryptic ways, IVIG is very, very complicated. But Xolair, right, for MCAS patients, remibrutinib can be a really nice option for some people. So more of the kind of immunomodulation that's where I certainly I think that can benefit some people, but certainly not everybody. And then broadly speaking, I'm just going to go out on a limb that I do think a lot of the MCAS cohort is due to barrier dysfunction. I really do. I think there's nothing inherently wrong with people's mast cells, like systemic mastocytosis. I think it's a barrier dysfunction. And if you change the way the immune system communicates with mast cells, I think people get better. But I think the inherent issue is, how do we improve barrier function? And I have no idea. I mean, there's thoughts and ideas, and I try things, but that's something fascinating in the interplay between the environment and our barriers. Like, how do we fortify them? Because I do think, like, why do we think COVID set off a lot of this? And there's obviously a lot of theories, but COVID through ACE2 and the enterocytes, right? And like really messing with barriers. There is a huge nidus for kind of the tailspin that can send people through. And obviously it's extremely complicated. I'm not dumbing it down to those things, but that's a whole world of interventions that we have not explored yet.
That's super interesting. There was a recent, just to geek out a little, there was a recent study that showed there was a correlation with blood barrier dysfunction with post-exertional malaise, and that the more that it was, the more dysfunction of the barrier there was, the more intense the post-exertional malaise there was. And
why do you think tirzepatide works well for a lot of people? It ain't through mast cells.
It restores barrier.
Eli Lilly's studying it to look at Crohn's disease and UC. If you look at people with IBD, with IBD who are on tirzepatide do better than without it.
Wow.
And so tirzepatide, I think there's NF-kappa beta, it's kind of immune pathways. But if you look at, when there's impending threat to our intestines, the L cells, the enteroendocrine cells of our jejunum release GLP to tighten up junctions. It's like, and so when you look at it through that lens, it's like, well, that's pretty cool. And why don't we lean into that more? but
That's really cool.
that's obviously, I don't know how to make drugs. So I just help people poop.
Um, Jen, why don't you go ahead? So, things you're interested in.
Yeah, no, I think definitely along the same lines as some of the things that Zach had mentioned. I particularly the immune regulation and also, yes, gut barrier dysfunction and things that are influencing like intracranial pressure and some of the structural and collagen. Like I'm very interested in those areas. I know there's, obviously there's an IVIG trial going on with NIH. We are trying Rhapsido or on quite a few patients, and we're seeing some really early great signs with that.
Can you clarify what that is?
Oh, it's a basically it's like if you have it's typically indicated for chronic urticaria, but if you have not responded to your standard antihistamines and whatnot, this is an additional one that you can go down. It's got a little bit of more of an upstream immune regulation pathway that it goes through. And so the other things too is some of the JAK inhibitors. Obviously, there's a baricitinib trial. Keytruda is going to be under trials. So I'm very curious about that. Um, there's some anti-B cell therapies that are being looked at primarily more so in Europe. I'm very interested to see kind of that expand beyond just like the smaller subset of patients that it's been trialed in so far. And I'm watching those very keenly. The other thing is from the Miss C in children, which was like a very significant complication of acute COVID in kids. There was lorazepam was studied in that, and I'm very curious to see if that can be trialed. I believe there might be something ongoing there for long COVID as well. And then, of course, there's the planned study for looking at the combination of Pemgarda plus Paxlovid. And then, recently, Zocova just got FDA approved for post-exposure prophylaxis for COVID as well. And I'm curious to see, I believe there's a small study going on in long COVID patients right now. I don't know if there's any results out yet, but curious to see on that one as well. So, the other thing I'm very curious about, that's like on the treatment side, but then also on like the biomarker side and some of the testing and phenotyping studies that are going on. I'm really, really excited for, the Viper program of like, let's go forward with a bunch
Yeah.
of things to try and figure out if we can better phenotype, if we can find diagnostic testing, because I feel like that is so critical in terms of figuring out which treatments are going to work for who is what do you have going on? Because there are different treatments you can pursue, but they tend to be very targeted on a specific kind of
Right.
downstream effect of like, what did this virus kick off in you as a person? And then how do we go back? Do you still have virus lingering around? Did it kick off other viruses? Did it reactivate Babesia or Bartonella in you? You kind of have to get at like, all right, what got kicked off? And then how do we go downstream of that? Because I think that we're going to end up, there's wonderful trials in progress, but if we're unable to kind of sub-phenotype properly, we're going to end up seeing that these trials don't work. There have been so many failed trials, and I think a lot of that is because we don't have the best way of selecting who would be the best candidate for that particular treatment. And things are going to work for a subset of people because this is such a heterogeneous condition that I'm concerned that, and I've spoken to many others who feel the same way, that if we don't start really, changing the way we do trials and do more like combination treatments or doing kind of like adaptive clinical trials, that we're going to end up with a lot of failed studies because we're not catching the subsets for which these treatments will work. And I ultimately do think that it's going to be something where we may, I am fingers crossed, like hoping we find something that's a silver magic bullet. I really hope so. But if we don't, it may be something where kind of like migraine that Charlie alluded to, where we end up, let's say years down the road, we end up with a bunch of on-label things, but it's still a trial and error process of figuring out which thing or which combination of those things still works best for that individual who's sitting in front of you right now. And so I know, we're trying to do some research on that ourselves and figure out if we can try and predict who's going to respond best based on treatments. We're getting some initial data on that, but this is very challenging space, and there's a lot of hope, but there's also a lot of like, we really need those tests.
A lot of work that needs
Is
to
a
be done.
lot of work that needs to be
Yeah.
done still. And, I'm really grateful too. There's so many incredible people who are doing just wonderful work in this space. And I'm just so grateful to all of them. And to the people who are, funding this research because, we know a lot of like NIH funding and stuff got cut. So I'm just very grateful to everyone who's working on this and pushing all of that forward.
And I'm grateful to all of you for working in this space. We know it's challenging, but as we've witnessed today, you're contributing and contributing a lot to the space and helping a lot of patients. And I just want to thank you. So why don't we move to a few questions if we can? But before then, I just want to make a few other acknowledge notices that this guide is going to be available in translations. And so I believe it is soon going to be available in French, and there is translations in the works on Spanish and Portuguese as well. So we are thinking about our international patients here and trying to expand access, to them as well. And the guide has now been visited by 45,000 unique visitors as well. And so appreciate, all the traction and everybody sharing it as much as they have. So why don't we start with Zac with this question here is how to deal with patients who are super sensitive to drugs, drug trials, and have had previous adverse outcomes from drugs. And anybody else, feel free to jump in.
That's a really hard one, really, really hard one. And I couched this, I think, to a patient saying that, like, I'm not quite sure that we're going to be able to press the right buttons, but we can certainly try in a very cautious approach. Carefully interrogating what has or hasn't worked in the past. And then if we have a specific goal in mind, whether that's treating one of the milieu of symptoms that people experience, then we start really, really low and go slow. I found there are certain medications that have more of a tendency to cause reactions than others for whatever reason. And if someone has, just listen to the patient, right? And be like, if they're like, I haven't tolerated this kind of medication in the past, I usually do not revisit it. I don't like to tempt fate. But I start one thing at a time, spaced out by a few weeks at a really low dose. I think I tell my patients this a lot when I sign an order. Oftentimes my electronic medical record system goes, this dose is way too low for any adult. I was like, you shut up, you stupid computer. You don't know anything. So I go really low. And then if you need to, you can compound medications as well. I do find, and this is completely anecdotal, that injection medications are generally speaking, I find better tolerated than oral medications, whether there's just a ubiquitous amount of mast cells within the stomach versus the subcutaneous tissue, whether injections have less excipients because it's usually just a medication and a filler or a buffer. But that's my general rule of thumb. And then I talk, I just follow people really carefully, and if they flare, then we pick up the pieces and try to figure out where to go from here. But goodness, it's hard.
Totally. Anything else, Benita or Jen, you would add to that?
What he said basically,
Yeah.
and I think the only thing I would add is sometimes people literally are like can react to the color, like the coloring,
Right.
those excipients. So sometimes if it may not be that they can't tolerate that whole drug group, but you just have to shop around and find the right. So I had someone who was really allergic to the salmon ivabradine, and then we managed to source some white ivabradine, and she was okay with that. So it's like really, she had really bad POTS, and she responded really well to the ivabradine. So it's like it's being kind of curious enough to try and think, well, is it the drug? Is it the excipient? Like, and it's just, yeah. Jen, anything to add?
Yeah, I think, in my experience, I do like to look at pharmacogenomics if I can get it to see if there's an issue with drug metabolism. Like, are they someone who's a very slow metabolizer of a drug? So like any little amount and it builds up very drastically in them. So they need very low doses. But then also with compounding pharmacies, you can ask them to send samples of just the blank capsules. So you can get dye-free capsules of various different kinds. So they're made out of different things. And you can have them just send empty capsules to the person and then also a little container of the different individual fillers they have. So whether it's like rice powder or like methyl cellulose, or sometimes they'll do like even like a probiotic they can use. And I have the person trial each thing one at a time. and we figure out a combination of capsule and filler that they can tolerate. And then I'll compound everything with just those components. Now, the problem is that when you do that with a dye-free capsule, all your pills look the same. So you have to be very careful when you're putting together your pill box, because if you put something in and you don't know if you put it in, they all look the same, so you can't tell. So I will do that. The other thing is sometimes, as Zach said, like doing things subcutaneously, transdermally, or sublingually, or even IV can bypass the gut. And sometimes the gut is really just driving all of it. I've seen both ways. Some do better with injection. Some people react to both. And it's kind of finding, yeah, what's that excipient mix they can handle. And, sometimes you even have to go as far as just raw drug in either water or like a type of oil they can handle. So like either like olive oil or grapeseed oil. And those don't last very long. So like anything compounded in oil has to stay, or like water has to stay in the fridge, and you got to refresh it like every week to every 14 days. It becomes very challenging to get that shipped. So it's like a whole thing. But sometimes that's what people need. And occasionally, when you can get somebody on, let's say, some ketotifen, you can get them on some things that they do tolerate. Sometimes their tolerance for drugs will then improve once you can kind of get the mast cells a bit more under control. And so those are just some of the strategies I'll use in approaching that.
That's great. Thank you all. Let's go to Benita with what is your experience, or do you have any insight into how these medications translate to a pediatric population? Anything you can share in that regard?
Yeah, so first thing to say is I am an adult physician, but we do have a children's clinic, which I run combined with a pediatrician. So the pediatrician does all the specialist prescribing and has lots of experience prescribing. Well, most pediatric prescribing is off-label anyway, but they translate really well, like the basic treatments for POTS, the basic treatments for mast cell activation, LDN. They translate extremely well in the pediatric population. Now, we don't see really young children; we tend to see children over 12. But I don't treat the children's population that differently to the adult population. They look the same, they behave the same, they have the same issues. What I would say is the pediatric population often have more complex neuropsychiatric presentation. So sudden onset tics, sudden onset OCD, behavioral change, and like this kind of pandas kind of presentation, and then that will need kind of more specialist input through an immunology or a psychiatrist who's got an interest or what have you. So they have got slightly different challenges in that sense, but the basic sort of POTS, MCAS management, migraine management, it's pretty much similar to the adult population.
Great. Okay, with the sake of time, we'll just move on to the next question here. I'll go to Jen. What medications or treatments do you tend to see to have the most success with ME/CFS or post-exertional malaise in general? And I'm happy to share my experience too.
Ooh, that's a challenging one, because I would say that, as Zach alluded to before, there are different triggers to PEM.
Right.
And there's also differences between cognitive post-exertional malaise. So for instance, the folks who are triggered by, let's say, reading or screens or interacting, like there's the cognitive PEM, there's sensory PEM. So like people who are triggered by light, sound, commotion, sensory input. And then there's the physical activity post-exertional malaise as well. And so I kind of tend to see differences amongst those as well as gradations within each. So it's not really like a super simple answer, but and I'd say variability. One thing, IV saline, to me is one of the things that's kind of a go-to. I would say kind of like a 50-50 response of like if someone's in a crash, or I kind of find about half of people tend to respond to IV saline to some degree. It may not fully get rid of it or fully prevent it, but it can kind of reduce the severity or help them come out of a crash a bit quicker. Usually I notice folks have to run it slower than you typically would. The effects may last for about like 1 or 2 days after they get an IV. But I generally don't like to try new things during an acute PEM crash
Mhm.
because you could make that crash worse. So what I generally try to do is have people just aggressively rest, aggressively pace, try to limit sound, sensory input, avoid triggers, hydrate well with oral rehydration that you tolerate, or just salt and water if that's all you can do, and just rest, wait it out. And then once you are out of that crash, that's when we can kind of look at what are some things we can try for you to reduce your further crashes and to give you a crash kind of um, protocol, so to speak. There are certain things like dextromethorphan that does help some people during acute crashes, IV saline. I've seen oxaloacetate help people with crashes, but it's very expensive. And then also things like, there's certain kinds of medications that, sometimes I've seen LDN lower post-exertional malaise for people, not necessarily on an acute basis, but help, increase their energy envelope, so to speak. I've seen IVIG help. I've seen everything across the spectrum. If they really have a mast cell driven case, I've seen ketotifen help dramatically. Um, it's a bit challenging in that sense to really say, here's the things that I see work the best. It really depends on what's going on for that individual person. I have seen also antivirals, longer term antivirals like help people significantly with that aspect as well. And treatment for underlying vector-borne disease as well. If they've got infection going on, like treating that can be very helpful. So I know that wasn't like the ideal answer, but um,
I,
I
it's a
think
very good answer to the $10 million question a lot of us are dealing with. But since it is the $10 million question, Zach and or Benita, anything else you would like to add to that?
Sure. Yeah. Everybody's crash is different. Like Jen said, I there are a few medications. I'm going to go out there and just say things that I find to be that I like to have in my bag a lot. Again, not for everybody. There are certain medications that I find that are just more of that move the needle more than others I've found. And Jen and Benita, tell me if your experience is a lot different, because I don't want to um, kind of color this one way and you're like, my experience is completely different. Um, I think that sirolimus has been really, really helpful for a lot of people, rapamycin. I find that in those who crash, but again, everybody's crash is different. More often than not, it ends up being successful. Um, I find that mestinon is a really helpful tool for a lot of people. And that's one of those kind of low hanging fruit, kind of doesn't really, if you start low and go slow, doesn't really, maybe not help with PEM as much, but definitely like expands people's energy window, so to speak. And then there's this kind of immediate after I do things, I crash, as opposed to kind of the next day classic crash. The GLP ones I found particularly successful for. But, I've also had people who really get hurt by some of these medications, right? And even at really low doses. So it kind of what works for the goose. And so it's, yeah.
Great.
Not much to add. I think that's pretty comprehensively covered by Zach and Jen. But the one thing that I do spend a lot of time focusing on is getting people's heart rates under control. So most of my patients will have an inappropriate increase in their heart rate when they do anything in the upright position. And it's in extreme cases in my bedbound patients that could be putting their head of the bed up by 15, 20 degrees, or literally sitting up on the edge of the bed. So making sure that we are treating that dysautonomia, that POTS, because faster your heart is going, the more energy your body is using up. And so getting that side of things stable really, really helps prevent crashes, alongside that kind of careful pacing and that micro pacing approach. So that's the only thing I would add in on top of what the guys have said.
And I would
Um,
add in just a little bit that also like the really low dose GLP ones have been increasing people's energy envelope, but they are not tolerated by everybody. And oftentimes I'm noticing we have to start people at a very, very, very tiny microdose and work up very, very slowly. I generally don't like to start it at the standard obesity dosing, especially if someone doesn't have any weight to lose, which is a common category in these conditions.
Wonderful. All right, so I think we have time for just one last question before we wrap up, and just want to thank everybody here. We've had over 600 attendees, and for the clinicians dedicating their very busy lives and inboxes for joining us today. But I think this is an interesting question, and we've touched on it a little bit. What testing can patients do to help figure out what options to use? Are there any um, diagnoses or labs you run that can help point patients, in the right direction of where to jump in general on the treatment landscape or in this guide. And why don't we start with we go Benita, Zach, Jen.
In the UK, I've got really limited access to any testing, so I'll do the basic answer and then hand over to these guys. But there are some basic things you can do at home. You can do something called a NASA lean test, which is just a test to look for POTS. And that's just taking a bunch of blood pressure measurements and heart rate measurements whilst leaning against a wall for 10 minutes, as long as it's safe for you to do that without crashing out. There are 24-hour ECG monitors can be very helpful for that heart rate dysautonomia that I was talking about. And a lot of patients have had these and been told that it's normal because those heart rate measurements are not being interpreted in the context of what that person was doing. So there's something about who's looking at the test, what you were doing at the time, and putting two and two together, going, this actually is not a normal heart rate increase. That's something that can be done. Wearable devices, things like the Visible app and with the armband or Garmin or those kind of wearable devices that are generally for health and fitness, but the Visible is specifically for chronic ill health. That can give you an idea of if you've got dysautonomia, if your heart rate's going too fast, it can help you pace. And then in terms of just general bloods, you can get little clues to mast cell activation, mainly through history, but also if you've got a raised IgE, that's something that general practitioners in the UK may agree to do. If your blood eosinophils are high, for example, that can be a sign that your mast cells might be misbehaving as well, because it's something that goes hand in hand. Trying to think from my repertoire of tests, what else? But I'll hand over to you guys while I have a think. But yeah, it's tricky when you can't access specialists and specialist tests.
Very well said, Benita. I don't have a ton to add. I think Jen will probably take it from here. I actually have an obligation at 2. So thank you so much for having me and everybody for showing up. And it was nice to spend time with you guys.
Thank you so
Thanks,
much.
Zach.
Thanks for joining.
See you guys.
Yeah.
So
Jen, why don't you wrap us up here?
Sure. So laboratory testing, I think, Benita and Zach went over great ones that you can kind of just do at home that you can get access to. Some of the things that can be challenging to get access to, depending on just if you've got a clinician who'd be willing to write for these things. We at Rhythm, we generally run a pretty extensive coagulation panel. So we look at things, and one we've come up with that's been abnormal in quite a few people is thrombin antithrombin complex. That can be run at Quest. We do run quite a few other things that aren't typically run in terms of coagulation. Honestly, it's a really pretty long list. If I went through, it'd probably just, kind of be just a bunch of words that wouldn't really make a whole lot of sense together. But maybe that's actually something we can put together later is like, almost like a step 2 of the guide is like, hey, what are some labs that might make sense? Because I feel like the labs need an explanation. And we don't necessarily order them always for everyone. Obviously, MCAS panels. So looking at things like tryptase, you can look at prostaglandins, you can look at, urine N-methylhistamine, you can look at, there's a whole range. There's consensus 1 for MCAS criteria, and then there's consensus 2 for MCAS criteria. They have different things that they will look at. Honestly, I think history is one of the biggest components of an MCAS diagnosis. Like you got to really suspect what's going on there and then rule out causes of, secondary activation. And then other things too is looking for occult infections. So looking for things like, do you have elevated antibodies or do you have positive PCR for things like Epstein-Barr virus, for HHV6? Do you have, obviously all the tests for things like spike protein and COVID in your body that may be persisting are all research use only at this point. But, if you have the ability to access those, taking a look at them could be interesting, but they may not necessarily be clinically actionable right away. We've really been getting into cytokine testing, and, finding interesting dysregulation there. I generally like to do an assay of like folks' immune system. So I like to look at lymphocyte subsets. I also like to look at a CBC with differential. I also like to look at their immune globulin levels. So Benita said IgE. I like to look at IgG, the subclasses of IgG 1 through 4, IgM, IgA, kind of look at that. And then, additionally, things like, have you been tested for tick-borne illness? Especially if you live in an area. I mean, there's so many areas now where you can get tick-borne illnesses kind of around the world at this point. And so if you haven't been tested for those, to me, it's kind of worth running because there's so many symptom overlaps, and that's very much treatable, right? So those are just some of the categories that I look into.
Yeah.
But, a lot of this is really there are other things, but I feel like I'm kind of rambling at this point. So I just
No,
want
this is
to,
music to a lot of patients' ears, and yeah, maybe we need to come up with a lab guide too or something.
yeah.
But
And actually, I will say, so Bateman Horn, the
right.
MECFS Clinician Coalition, it was originally designed for MECFS. I'm part of that clinician coalition. Dr. Cindy Bateman, her colleagues at Bateman Horn Center, many other clinicians who worked on this. There is a guide to labs, and that can be a good start for folks in the interim, checking a look at that. So you can either go to the MECFS Clinician Coalition website. I think it might also be on Bateman Horn's website as well. I'm not 100% sure, but it's a great resource to look at and get a starting point for now for the labs.
Wonderful. Um, okay. Well, thank you, uh, Dr. Kane, Dr. Curtin, for sharing so much of your incredible wisdom today with everybody and giving everybody, some hope that there are, some, you know, opportunities, to improve and, with our quality of life. And hopefully this guide can help some folks, on that journey. And so, yeah, I don't, unless you have anything else to add, I think we should wrap up.
No, just thanks very much for having us, and for the audience, like amazing
Yes.
turnout, but also the chat's just been going nuts the whole time through. Everyone's been so engaged, so thank you everyone, and for your kind
Yes.
comments as well. Really appreciated.
Yes.
Yeah,
All right.
thank you
Yeah.
so much.
Okay. Thank you all. See
Okay,
ya.
bye everybody.